All right, Dr. Kenan Omurtag here again, continuing the conversation about Asherman syndrome. This is the video that we're going to talk about what the causes are, how does Asherman syndrome occur, and then talk about the testing that's associated with it. So if we go back to this picture, there are several different, remember the uterine cavity, I think first of all to understand the uterine cavity, you have a thin layer of what basically are germ cells that provide the cellular activity to grow the uterine lining. So you have this germ cell layer here that makes an endometrial lining in response to estrogen. Okay, so this lining grows and grows and grows. However, if you harm, or if this is breached, and this layer is damaged in any form or fashion, then it cannot, scar tissue forms and it becomes a magnet for attachment, especially if there's scarring on the other side as well. Then these sides pinch and then you have scarring here, okay? So what can cause breach of that basal layer? Perhaps one of the most common things that people talk about is any kind of instrumentation in the uterus. So instrumentation. So instrumentation in the uterus, specifically like a DNC, is what people think about being associated with any scarring in the cavity. Now again, having one DNC, let me be clear, is not going to increase the risk, or is not going to cause Asherman syndrome. Anytime you put something into the uterine cavity, there's a risk of introducing infection, and then there's a risk of damage of this lining. In the modern day, DNCs are performed with suction and not sharp curettage. So when there's sharp curettage, there's scraping of this lining, and it's more likely to breach into this basal layer. But what the current instruments for DNC, if you have a miscarriage, for example, it's usually suction, either manually or with a vacuum. And that's not enough to cause trauma. So just having a DNC is not going to cause Asherman syndrome. However, the conditions around it may be associated with an increased risk. So, and one of the common things that I see is if someone has retained placenta after a delivery. After a delivery, this is a very vulnerable area. You can have retained placenta in here, and in an effort to stop persistent bleeding, infection, evacuating this placenta requires dilation and curettage, and this area is very vulnerable, and you can increase the risk of getting a breach into that basal layer and causing some uterine synechia, and in some rare cases, Ashermans of a portion of the cavity. All, again, very correctable, but these are the kind of things that can increase the risk of breach of that basal layer. If this basal layer is destroyed completely, then it's not capable of proliferating the endometrial thickness that is required for implantation and shedding of a lining to normally occur. So then this becomes an area that there's no ability to correct this unless you introduce germ cells into the uterine cavity and then they can reimplant, which some people have tried but still remains experimental. Other causes are infection. So you can have an infection, whether it's an ascending infection, whether it's from instrumentation, whether it's from some other random source. You know, someone had an IUD in place and then had an infection at the time, which is exceedingly rare. But these are the kind of, any kind of infection in the uterine cavity. Maybe they had a retained placenta that lingered for a long time and they developed pelvic inflammatory disease. An infection can breach this lining and cause scarring. Other things, surgery. So if someone has a surgery whether it's through the uterine cavity or from the outside for like a fibroid, if the cavity is breached, so if someone has, let's say, a fibroid out here, and in removing the fibroid, the cavity is breached, that can be an area of scar or distortion and that can be corrected rather easily depending on the extent. Ablation, this is where in a treatment, someone who's had, you know, they're maybe done with their family building, they have 2 children, they have abnormal uterine bleeding, they're sick of it, but they still want their uterus. Some gynecologists will recommend an ablation where they put a device inside the uterine cavity that then just burns the lining and basically destroys the lining. Usually if you're having an ablation, you're committing to being done with building family or getting pregnant on your own. Obviously your ovaries are fine, so you could still create embryos with your own eggs, but your ability to carry the pregnancy is impaired. This is usually a very challenging scenario. It is very difficult, if not impossible, to reconstruct endometrial lining after an ablation. And in my experience, this has not come to fruition. I have not been able to, people who have had a full ablation, it can be challenging to correct. And oftentimes we're having conversations about gestational carriers early in the process of attempting any correction. So these are all the causes, or perhaps the most common scenarios that I see, and many physicians in my situation will see where there's any kind of uterine synechiae and or severity like Asherman syndrome. Usually what we do to diagnose Asherman syndrome, if we then kind of pivot to diagnosis, is we want to do a special type of ultrasound called a saline infusion ultrasound, where we try to push saline into the uterine cavity and see what expands. And you can get varying levels of expansion. Sometimes you get a situation in which the uterine cavity completely expands, and there's maybe an area over here that's scarring or a little synechiae, that's easy. Sometimes you just get this area here that's open and this area is obliterated. Sometimes the entire cavity is obliterated and you can only get the catheter here. There are varying levels, and the saline infusion sonohysterography helps us set expectations about the extent of any scarring in the uterine cavity on our way to correcting it. So in the next video, I'll talk about how we correct Asherman syndrome and uterine synechiae and how we set expectations about the surgery moving forward. Hope you enjoyed these videos. Hope they're helpful. Again, talk to your physician about what your situation is and what the approach is, and what the expectations are moving forward. Because again, not all Asherman syndrome is the same, and the approach varies. See you on the next video.